This is Jimmy Whittyfield and Paul Shawler. Can anyone hear us?
Yes, this is Sue right here. Hello.
Hi, Sue.
Hey there.
Team DNLCC.
Great.
And Cheryl Overby from Lutheran Family Services in Omaha.
Sure. How are you?
Good.
Great. Good to hear your voice again. We have some additional people joining right about now, so we'll wait just a few minutes before we get started. I'm going to mute people until then. Do a couple things so it reduces on some background noise. And you can always unmute yourself by clicking on the microphone next to your name, to the far right of your name on the screen. If you're not joining in front of a computer, I'll unmute everyone here in just a moment as we're getting started. Hi, is that Kristen McNeil?
Hi, this is Blair.
Blair?
Hi, Jimmy. How are you?
I'm good, thank you. We have a variety of people on the phone.
Okay.
We're going to just a few more minutes, so I'm going to put everyone on mute.
No problem.
All right, I'll unmute you in just a moment. And I saw that Kristen Neal just joined.
Yes.
Hi, welcome.
Hi. Thank you. I'm actually with Lena Pope. I'm helping Stacy Lewis out today by attending.
Oh, wonderful. Well, we're glad you're here. Thank you.
Thank you.
I'm putting everyone on mute right now just for a few minutes as people are joining. And I'll mute everyone as we're getting started.
Okay.
And welcome. If you're just now joining us, we are waiting just a couple of minutes so other people can join with us. I think the person who just joined is Dr. Jane Solewski.
Hi, everybody.
I have Jane.
Okay. Oh, no. Control.
That'd be easiest if people are joining to reach down on some feedback or background noise.
Good afternoon.
Hi, hello, welcome. Who is this?
Hi, this is Cecilia Dutela from OJJDP.
Great. Welcome to the call. I'm muting people right now as we are. People are joining just so it's not a chorus of noises.
Perfect. Thank you.
And I'm changing. Hello and welcome.
Hello, this is Marlise Whitehat.
Hi, Marlise. to hear your voice.
Thank you.
I am people for about the next 2 minutes. Actually, we should go ahead and get started. It is about 3 after 11. So I'm going to start unmuting people. Once the presentation gets started, it is best for us to mute people to help reduce background noise during the presentation, or you can mute yourself. You mute yourself by your phone if you're joining by computer, doing that as well. We'd like to welcome everyone to the bi-monthly OJJDP Journal Club meeting for youth with problematic sexual behavior. I am Jimmy Whittyfield Jr., one of the training and technical assistance providers for the National Center on Sexual Behavior of Youth. I'm very excited today that Paul Shawler is joining us. Mr. Shawler has been a member of our clinical program here in Oklahoma for 4 years, and has amazing experience, is sharp as a tack. We're very lucky to have him today to present on the topic of developmental disabilities. It looks like we also have representatives from sites across the country. I'm very excited that Cecilia is with us from the Office of Juvenile Justice and Delinquency Prevention. Other members of our team are currently also on the call. There's Ben Siegel, Jane Solevsky, and Carrie Schwab. And Dr. Bonner, thank you. Wonderful. She'll get on to me later for referring to her as Dr. Bonner. I should have called her Barbara.
Thank you.
Also, it looks like we have folks joining from sites in New Jersey, the Rosebud Sioux Tribe in southern South Dakota, from Fort Worth, Texas, from Charleston, South Carolina. Sue Right-Hand is on the call. She's a member of our team. She is in Maine. So it's really a good swath of the country. Just a couple of quick reminders. In terms of logistics, if you have any thing that you need during the webinar, you can use the chat function at the bottom of your screen, or you can call or email, of course, from a separate line. We can help you that way. Please make sure to reduce background noise. You can mute yourself either on your own phone or through the computer if you're joining us in that modality. That does reduce echo, feedback, and other background noise that could be distracting. And when you have questions and you are speaking up, if you would please introduce yourself by name and location, and then give us your question so we know who is speaking, how to respond best. So with that, I'm going to turn this over to Paul Shawler and let him take over. So we are having him. Thank you, Paul.
Hi, everyone. Thanks for joining us today and being part of this phone call. It sounds like there's broad interest in really trying to understand how to treat and how to assess those with developmental disabilities, especially when sexual behavior is involved. So the article I sent out for review is a very behavior analytic journal and is much different than a lot of our training backgrounds. And so what I hope to do today on the phone call is really to talk about what are those key assessment points that we want to get working with families that have children with developmental disabilities, and then what are those treatment components that are both similar as well as maybe different within this population. I had a PowerPoint, if you're on and viewing the slides on your computer, I had a PowerPoint that had functionality, and so I'm going to be using the pointer that's on the screen to walk you through some of those slides. There will be 2 points during the presentation where I'll ask for explicit feedback, but if any time you have questions or need clarification, please do so. And with that, I'll go ahead and get started. To give a brief review of the objectives in a very quick time, given the phone call, I'll review the spectrum of abilities that children with intellectual and developmental disabilities possess. Again, talk about that assessment, look at the corresponding comprehensive treatments to help these families, and talk a little bit about the differences that we tend to see with some children with developmental disabilities as far as how often problematic sexual behaviors occur compared to most of our youth that really come into treatment with a lower rate of problematic sexual behavior, although still problematic at any rate. I'm going to share some resources with you that will help you augment your treatment service. Resources will be at the very end of the PowerPoint and are free downloadable online resources specifically regarding sexuality and teaching children with developmental disabilities. So to start, when it comes to the assessment, it's important to know the trajectory of a lot of the children, any children that we assess. And so every child goes through toddler years, every child goes through middle childhood, and of course adolescence is a stage where sexuality and relationships become much more important. But with the developmental disabilities, understanding that developmental age and chronological age are two separate things. And so I have a gray line here that just represents some kids that start off with an early developmental delay, and as they grow up, they meet up with their age-appropriate peers throughout childhood, but then fall slightly below their adolescent peers as they age. And then the red line represents somebody with a greater delay, where it takes them several more years to catch up to their peers, but in adolescence, they fit in and catch up to their peers over time. And then today's presentation really focuses mainly on this bottom blue or black line, where kids have a developmental delay, and that transcends across the toddler years, the childhood years, through adolescence, where there's a stark difference between developmental understanding and where they are compared to their chronological age peers. And there's a lot more detail that I could go in to this slide, but I'm going to go ahead and move on for time's sake. The important parts that I want to say front is that every developmental disability is extremely different. Every individual that we treat, developmental disability or not, is a unique individual. You can have developmental disabilities that range from intellectual disability with low adaptive behavior, things like Fragile X or children with Down syndrome, some children with autism. So there are a number of genetic conditions as well as just other developmental disabilities that can span the spectrum of they have verbal capabilities, how are they able to learn. So trying to take into account those individual differences is the first part to understanding how we're going to treat and intervene with problematic sexual behavior. So although there's several unique things, there are a couple common things across any human being, regardless of developmental disability or not, and that's all that children are sexual beings, and that is pronounced during the pubertal years. And so every single human being has sexual feelings, their own preferences, and sexual activities that come about as part of growing up. And I included the Keep Calm and Survive Puberty slide because it's almost like a second awakening for grown-ups that work with these individuals, because they frequently require different efforts as children age. So when thinking about social awareness and sexuality, think about things that every toddler and child is learning as they age. Learning gender roles in whatever environments that they're in. They're learning to keep their clothes on. They're learning to get embarrassed if they don't have their clothes on and to keep privacy. And so, however, all learning about sexuality and social awareness is trial and error, and it happens over time. And the purple one really indicates as children age, they have different trials, opportunities with relationships, with sexuality, and they're learning over time gradually without getting in trouble. They're staying within those social norms. That's what we expect. And in adolescence, you might have more peaks and valleys, but again, they're staying in that mainstream norm. The green arrow, which takes a stark difference, is really our kids with more severe developmental disabilities that really lack or have a hard time picking up on social awareness. In those homes, it may be typical for families not to really reinforce wearing your clothes because it's such a struggle. Having relationships with other kids can be extremely difficult because they just want to be by themselves, or they don't know how to fit in, or other children don't pay attention to them the way that they want to. But then all of a sudden you hit adolescence, and there's a stark difference because, again, every child has sexual urges, sexual desires, and interests for various reasons. In adolescence, all those things come about, but without having that foundation of skills, it can be extremely challenging for these kids. Oftentimes, they get caught having problematic sexual behavior because they're trying to navigate a system that is brand new to them. I included a couple other lines on this slide just to talk about varying development of social awareness and sexuality. The yellow line, again, is a child, maybe more commonly that we would see even within our group, is where they have this toddler and childhood years with delay, but as they enter later childhood, they kind of catch up to their peers. They may be somewhat socially odd or awkward, but still have opportunities and chances to have some of that trial and error learning. It's familiar to most of us on the call. The blue line oftentimes represents a lot of kids we get in group that do have some of those just really social, they do fit in, but at the same time, there's just some differences between them and their peers and those learning opportunities, so they fall below some of their average peers within their peer group. And again, oftentimes that leads them to get in trouble and or some of our services because the lack of awareness or understanding that their other peers have. So the presentation today is not going to focus a lot on the specific risk factors of these children. I can point individuals to various publications, but I did want to point out that there are several risk factors that may lead up to these kids being more likely to get in trouble for their sexual behavior. And a lot of that includes lack of information about and experiences for relationships because, again, the difference between them and their average peer. The social skill avenues, if you're working with kids with more severe disabilities, they don't get out into the community. They're not playing sports with their peers. They're not involved in as many activities, and so they don't have that same foundational knowledge. Sexual education, if you talk to the parents, it's like, hey, have you ever had this conversation or thought about having this conversation with your kids? And it's extremely limited, and parents are fearful about teaching sexual expression because they're afraid that their kids will engage in problematic sexual behavior. It's frequently left out of schools within this subset of kids. Fortunately, having developmental disabilities really puts the children at higher rates of abuse and trauma, both physical and sexual abuse, because they tend to go along with what adults or authority figures say. They listen to other people because they think it may make them popular. There are several reasons that there are higher rates of abuse and trauma within the developmental disability community. Exposure to pornography is a risk factor for all of our kids, but with kids that have a hard time receiving information, seeing it, and trying to model behavior, again, understanding appropriate interaction and the difference between real life and what they see is a hard lesson for a lot of these kids. Again, the difficulty really understanding consequences and emotions are two big aspects that oftentimes fail that social boundaries contracts that most kids develop. So I put this slide together to talk about why is this population really difficult to work with, especially within our background and our special mental health services. And it's because children with intellectual disability have their own community and own specialists that they work with. Mental health, we have an idea about assessment and some treatment, but developmental disabilities don't fill up the majority of our caseload, so it's brand new. So all of a sudden, if kids are having problematic sexual behavior and they enter different service systems, not one single service system is totally equipped to deal with this population. And so children with intellectual and developmental disabilities, again, are more likely to experience child maltreatment, and so there's normally child protection services involved at that point. Children are more likely to have mental health conditions, whether that be disruptive behavior or other conditions. Children with intellectual and developmental disabilities are really overrepresented within the juvenile justice system as a whole, because a lot of these kids do get into trouble because of impulsivity or not really understanding the social norms. And unfortunately, some of these kids are raised in an environment without the supports needed to continue to make good choices. And once they enter the juvenile justice system, there tends to be a lack of support, awareness, and understanding about how do you treat these kids to make sure that the future is better than what led them into the system. And we'll talk about how do you formulate goals to hopefully make those things better. So within the juvenile justice system, we have this R&R model, which really looks at the risk, the need, and the responsibility for kids in treatment. And assessing risk for future acts of problematic sexual behavior or any kind of disruptive behavior problem with developmental disabilities can be hard because there's so many different systems involved, so many different supports required. Predicting risk is difficult. There are a lot of needs within the service system, and we're trying to say, what does this individual have around them to make them responsive to learning, to their environment, and their ability to receive and be successful with certain support. And we'll talk about those supports as we go. So assessment for any kid really does start with understanding the individual. Even more so important with kids with developmental disabilities. Understanding how did this behavior start? When did it start? Did anything happen around that time? Really understand how to learn this behavior. Why is it continuing? So looking at the course, how has the behavior changed over time? What does the behavior look like? How long does the behavior last? What does the duration look like? Frequency, how often is it happening? Impairing and why? And so we'll talk about each one of those as we kind of move forward. But that is some bare essential information to collect during an assessment, especially when you have kids with developmental disabilities. Understand the full picture of the behavior that is occurring. As we move forward in an assessment, it's really important to understand, especially with high-rate behaviors, why the behavior keeps happening. And so what is reinforcing a certain behavior to maintain its occurrence? And we tend to look at those things, functional assessment, which really looks at three different domains. We look at antecedents, which happened before the behavior, what is leading up to the behavior. We look at the behavior itself, again, those questions of what does it look like, when is it occurring, how long does it last, and then we look at what happens as a result of that behavior with consequences. What we know is that most treatments are going to look at what happens beforehand that we can change, what do we do afterwards to hopefully make sure that this behavior is less likely to occur in the future. So as an example, and this is one where I would like for you guys to chime in, is about this behavior. So John, he's an 11-year-old with Down syndrome. At school, he removes his pants after lunch in math class and attempts to touch his private parts on his teacher. Other students laugh. John is removed from class and sent home. What do you guys think that behavior may be occurring?
How old is he again?
He's 11.
11.
He may like math class or understand the material in math class.
Absolutely. So math may be a hard subject. So that's a possibility that he's having some disruptive behavior.
Maybe bring some social gratification of other kids, making other kids laugh. So that might be reinforcing them as well.
Yes, some social attention, for making other kids laugh, and a lot of these kids, they really want to be popular because they see their other kids being popular, and if they see laughter, they're not be able to understand the difference between what is good attention versus kind of negative attention. Reasons?
To go home, he might want to go home too, and he knows that he's learned that that's an easy way to go home.
Yeah, if he gets to go home and play on his video games, that would be a good thing and a guaranteed way to make sure that he can go home and do that.
I wonder, how much does John understand rules around privacy and boundaries with body parts between him and authority figures?
And so that's one thing that we're going to look at when it comes to teaching, and when he's engaging in certain behaviors, maybe he doesn't understand certain variables. Yeah. What do you think of?
I was thinking maybe because of his age, maybe he's having kind of early onset of puberty and kind of not knowing how to manage those feelings, maybe developing, I don't know, some anxiety around that and not being able to, maybe urges.
Yeah, absolutely. So going through puberty and having erections and having different feelings can be something that can be difficult for these kids to really understand. And if it feels good or if they get anxious, get worried about having an erection in class, maybe they start to do things to try and get out of that environment. So whether it feels good or whether it's trying to get out of the environment is something that we really want to understand. Again, you guys really picked up on the major aspects of understanding what behavior, why is it happening, and what can we do to change that. And so,
Sorry, Paul. I was just going to add that we don't know much about what goes on in lunch and, who's there and what that might be stimulating as well.
Absolutely. So maybe some kids put them up to it at lunch as a dare. And is there some supervision concerns going on before the behavior? So that's definitely something that we would want to explore. And the assessment questions that I think are really critical when these families come in is, why does this behavior keep occurring? Is this a daily thing? Was this a one-time thing? How did other people respond to it? What did the teacher do? What did the teacher say? What did mom do at home? What did the principal do? Other kids in the classroom laughed. They were in the classroom. And then to look at, what are those antecedent or consequence changes that we can do to decrease that behavior to occur again? And what skills do John need to learn to develop in order to be successful? I think all our guys' exploration about potential ideas are going to lead to an effective treatment for this individual. And you know that kids do things for various reasons, and you guys pointed out several of them. So look at the consequences, or really what is maintaining behavior in this example. It could be attention. It could be the negative attention he's receiving from his teacher. It could be the positive attention he's receiving from his peers. It could be that, again, he wants to go home. It might be that people leave him alone when he gets in trouble, and he likes it better that way. It's to gain access to different items. So when I get close to others, they start giving me things, so I leave them alone. Or it could be, again, some behaviors just feel good, and teaching appropriate ways for children to experience normal sexuality is a crucial thing in order to be successful. Treatments really look at the ecological model and the system supports within what I'm going to call an idiographic assessment, which is really just tailored to the individual, looking at their specific circumstance and the strengths and supports of their family system, their school, and their neighborhood. And this is where treating kids with developmental developmental disabilities can complicated because they tend to be involved at all levels. And understanding attitudes of culture and communities can be challenging within these systems. Assessment considerations, and this was the other document that was sent out today with a reminder is that ATSA just published assessment and treatment needs for those with intellectual and developmental disabilities who are exhibiting sexual behavior problems as well as offending behaviors. And so they came up with a list of here are some things that definitely need considered during assessment. So again, what are those? The cognitive abilities as well as the adaptive functioning. How is the child thriving in their life, and what are they able to understand? Every individual has strengths and assets that allow them to learn and be successful. What is that? Again, the developmental and the familial history that led the individual to be where they are today, both with strengths as well as some things that we might want to get better. We look at the family strengths and abilities that they currently have, both in time, energy, and assets. We look at mental health history, current diagnoses, current medication, because again, some of these kids will come in and if they have a problematic sexual behavior, depending on the psychiatrist that the child may see, various treatments could be prescribed, and whether they're frontline or not is a matter of question in how we maximize that individual's functioning. Same thing with learning history, how they've been successful to learn in the past, and where are they at within their education, as well as where are they with sexual history, including problematic sexual behavior. List factors, whether they're in a stable environment or not within the family system, and whether that'll change, as well as their environment. Again, these kids are involved in numerous social supports, whether that be speech therapy, occupational therapy, physical therapy, or other school-based interventions to make them successful. So really getting a good picture holistically about where kids are, where they're functioning, and how can we make sure that they're learning the skills that we want them to learn in treatment. So curious, this is another one, and for those of you that were able to read through the article that was sent out by Davis and colleagues, what were initial thoughts about some of the interventions that they reviewed for kids with developmental disabilities and problematic sexual behavior? Again, that they're much different kind of our treatment model.
One talk at once.
One of the things that I hope you guys can do, and I think I can actually pull it up for those that are on the computer, this is the front page of the article. Let's see, I think, yeah, I can scroll through. There's a table on page 5 that really goes through different types of interventions. It goes through a description about what kinds of procedures they used in these studies. It went through strengths of each approach, and then it also talked about potential limitations. So how much time does it take? Could it be counterintuitive to use one procedure if you're doing something else? And so if you have a few minutes, it would be nice, if you don't have time to read the entire article, to scroll through that list and to brainstorm what that treatment look like, what does it entail? And I'll do so briefly here on the upcoming slides. One of the most important things that I really wanted to discuss was that with the field of applied behavior analysis, their treatments for kids with developmental disabilities look significantly different than a treatment model with a manualized curriculum, and the outcomes that are assessed are completely different. So within the article, most interventions were actually delivered by trained professionals, and and implemented by trained professionals. Whereas in our treatment model, we have our once-a-week appointment, and the parents are the sole responsibility to carry out and practice the skills learned. And so whenever meeting with families, it's really important to assess where is the family and what are they able to do, what are they capable to do, and how can I make it work within their system. So we look at developing individualized treatments for these kids. A lot of the models that we use to treat our kids with typical developing kids with problematic sexual behavior are the same things that we want kids with developmental disabilities to learn. What we know is that a positive approach to teaching and learning tends to be more effective than an aversive approach. And so I really liked that the AXA publication put out goals for treatment. So they termed goals to either be avoidance goals that we want kids to stop doing, or approach goals, which are things that we want the children to learn and the things that we want the children to do. And so if you can think back to most things on positive psychology, is we tell children what we want them to do and do it. And it's much more effective than just telling them to stop or to avoid certain things that get them in trouble because they don't know exactly what to do with their time. So certain approach goals, especially for kids with developmental disabilities, is what are the bare basics that we want them to understand? Does a child understand the difference between private and public places? Do they understand what behaviors are okay to do in public and what behaviors are okay to do in private? This happens pretty frequently, like questions about sexuality. Is it okay to ask questions about sexuality in the middle of Walmart? No, it's not okay. Is it okay to walk out without clothes on in your house? No, that's not okay because there might be other people out there. So really teaching private and public behavior as a foundation level skill for kids with developmental disabilities is extremely important. And there's a great resource at the end that I'll share with you that's free to download to teach that. Trying to understand emotional awareness and regulation, it can be extremely difficult for these kids, just like our other kids with problematic sexual behavior that we treat. How do we get them to understand and identify their own emotions as well as other people's so they understand social cues? If somebody says stop, that they understand what that means. And again, relationship skills, which build up to the sexual behavior rules and communication. How to teach sex education to this group of individuals? It has several differences as far as effective teaching for sexual education. Lucky for us, several people have built excellent curriculums to teach education for kids with developmental disabilities, which can also be shared at the end of the webinar. Abuse prevention in this population is even more important. I don't want to say it's even more important. It's important for all kids. But again, given the high risk levels for kids with developmental disabilities, how do we teach them what is appropriate and not appropriate behavior for them, but as well as for others to do with them? And social skills can be tough because if the kid says, hey, it's going to be awesome if you do this, try to get kids with developmental disabilities to understand that sometimes kids don't tell the truth, even if they want to be your friend or say that they'll be your friend, maybe not be true. Get to be active in their community, have healthy hobbies and enjoyment. So I've seen several children with developmental disabilities that as soon as you give them things to do, environment, you enrich their environment, you give them friends, all of a sudden their sexual behavior goes away because they're thinking about other things and they're being successful. Skill building is crucial for these kids, so how are we tracking them throughout their educational as well as vocational goals, which the families will often bring in several ideas for. Webinar is so short to teach how you actually teach these skills, but there's general ideas of teaching children with developmental disabilities, which include visual support, including pictures of exactly what is okay and not okay to do, hands-on practice activities that get them up and moving so they can see what's appropriate and how to do it. how do you effectively shake someone's hand, greet them, give them even an appropriate hug can be a challenge for some of these kids. Repetition is key, taught and practiced in multiple environments, both in therapy as well as home. And patience and repeated attempts to boost that understanding. And this is where the caregiver piece really comes in, because caregivers know their kids than anybody else and know what works best for their kids. Really trying to get the family on board is crucial. And again, the online free resources do a great job at really explicitly saying, here's how you set up these activities that can go through. So when we look at that, the functional assessment, we really have three different options when it comes to augmenting our standard-based treatment. And how do we change what happens before a behavior? How do we happens after a behavior? And the schedule-based intervention, which is really how can we add in and make the environment better as a whole, regardless of the sexual behavior that's happening. So sometimes enriching environment can go a long way for these kids. So the question that's posed is, can changes make huge differences in the case of problematic sexual behavior with those with developmental disabilities? As therapists, we get referrals for kids with developmental disabilities, low IQ, and we automatically assume treatment model and my skill cannot be appropriate for this individual. And so part of the webinar is really advocating for you to take a closer look at the skills that you have, the station that you possess, and the ability to make huge differences. Just telling parents very simple directions and teaching children very basic skills can all of a sudden make problematic sexual behavior disappear. And so just as you hear intellectual and developmental disabilities, I urge you not to automatically screen out those referrals, but really consider, what does this child need, and agency, and do I have the materials and knowledge to help this family compare to the rest of the community? And most of the time, the answer is yes, you do have those capabilities. And within the article, they really talk about 7 different types of procedures for kids with developmental disabilities that are exhibiting problematic sexual behavior. The first one is called instructional revision. And so when I hear that, I ask the question of, can you set up the environment differently? How can we make it more positive? And so in the instance or example of John, we had a child that maybe didn't like math. Could we make a math exercise simpler? Could we make it shorter? We make it on his level? Could we change math to morning where he's more likely to be focused and calm, and then put something like music after lunch? And again, these things are not easy to change in schools, but questions that we can have that can help our children be successful. Is kids at home, a lot of kids with developmental disabilities that are growing up, going through puberty, some of these kids aren't left alone because their parents, I don't want to call them helicopter parents, but sometimes you have parents that don't let their kids have private time or alone time because they're so used to being an active parent. And so when that happens, and don't have the natural sexual expression that they might have in private, and so maybe they're going to have sexual behaviors in public. The next one is this manipulation of motivational variables. And this is saying, like, are we really meeting the needs of the individual? So are we giving the child enough attention? So again, kids that are at home and left alone a lot of attention often because their parents are exhausted or they're working, and so kids will act out in order to get attention. So how can we embed activities before a behavior problem starts? Thing with what they refer as non-contingent reinforcement is, are we making the environment positive enough? And is there enough fun activities to compete with sexual behavior? As know, in adolescence, especially for males, activities are very reinforcing, and so trying to figure out what is fun and appropriate that we can build into a child's routine to compete with sexual behavior can do a world. So I'm going to go through these relatively quick for time, and then I think that we have a couple questions that have came in through the chat line. So be thinking if you have other questions about specific cases or about things that have came up with assessment and treatment that we can address on today's call. And again, this is a very brief overview, but how do you actually implement these things freely takes a longer discussion. So other things include differential reinforcement of alternative behaviors. So for those of you that are really familiar with developmental disabilities, they call it functional communication training. So a child is acting out with sexual behavior because they're trying to communicate something. I need help, or hey, I want attention, or hey, I need a break. Is how can we teach that child to ask those skills instead of acting out in order to get their needs met? So again, it's changing happens before the behavior in order to make an impact on the outcome. Same thing with differential reinforcement of other behavior is each child is having problematic sexual behavior. How to point out the good things that that child is doing to reinforce it. And that's the same thing that we tell all of our families is when the child is being good, make sure you point that out and you praise it. Same thing with kids with developmental disabilities, and that's probably the number one treatment goal that I have for most of the families that I work with kids with developmental disabilities is how do we find what an effective motivator with social reinforcement, which helps for social skills and understanding, as well as just making that environment enriching instead of reprimanding. Extinction is much harder, but it is referenced in the article. The big thing with children with developmental disabilities is trying to avoid the negative reinforcement cycle that adults frequently get into, where parents and teachers or even therapists are saying, stop, like, do this, or give attention to that negative behavior, and simply withdrawing yourself and making sure that the child is safe and other children are safe frequently says, hey, that behavior is not okay, and the children learn to develop other types of behaviors. And lastly, are standard methods of consequence-based interventions, which include punishment procedures. So that can be as simple as developing a response cost. So if a child engages in problematic sexual behavior, having a very set specific consequence, so you can watch TV for the next 2 hours. Timeout is an option for some kids. As long as the behavior is motivated by social reinforcement, punishment procedures can be effective, whereas if a child is trying to get out of a task or it's self-reinforcing, timeout necessarily, it's not going to do anything to decrease the behavior. It actually may increase it. Trying to think through different procedures carefully is important. So as we wrap up here on the tail end, I just want to highlight the importance of working with family and the family support. So these are families that frequently come in, and extended family can be involved. Some of these kids can be within the system and have different social agencies being supportive, and understanding all professionals are involved with developmental disabilities is of most importance. And parents and caregivers want the best for their kids, and they're the best advocates in order to have those needs met. Best how their children learn, respond to situations, and feel, because sometimes as a therapist, especially if you're doing once-a-week therapy, your interactions with a child with developmental disabilities are extremely limited, and sometimes teaching parents how to teach children or what to teach children can make the biggest impact. They are best, and again, these families can be overwhelmed, but they are trying their best within the system which they live in order to implement strategies given. So trying not to get frustrated if things take more time than others, just because they're the way that the lives have to be run in some of these households. And that follows up with just meeting families where they are and to be open. And to wrap up, the free resources that are available for download include The Sexuality Across the Lifespan for Children with Adolescents and Developmental Disabilities. This was a publication and outreach effort by the Florida Developmental Disabilities Council. This is primarily a reading-based information publication for parents to understand puberty, difficulties in puberty, and how do you go about formulating a curriculum to teach kids appropriate behavior. Favorite resource I'm going to share with you today is this Healthy Bodies curriculum that was put out by Vanderbilt with their Leadership and Education and Neurodevelopmental Disabilities trainees. This is a hands-on training that teaches those differences between private and public behavior, appropriate and inappropriate behavior, and then talks about types of different relationships you can have with others, and it's completely available for download for free. The third resource is a website that is a parent-based website for parents with kids with all kinds of developmental disabilities, go through how to teach and what are some activities that you can do to work with these families. And so there's activities for kids with physical disabilities, visual impairments. They go through a number of different things. And so it's a great resource to look through when working with these families. In fact, I have a question here that says, when these children need help with toileting issues and private parts are not private, are there suggestions for teaching this concept? And so toilet training tends to be a very big issue with several kids with developmental disabilities that can span through adolescence, sometimes somebody's entire life. Toileting can be challenging. And so really trying to teach what parts are private and who is allowed to assist with toilet training. And so if you look on the Healthy Bodies curriculum, and if you look through sexual abuse prevention that's already within the model, use those pictures to teach, is it mom, is it dad responsible for toileting? And taking real-life pictures and implementing them into your curriculum can be extremely helpful. So who is okay to help with toileting? So do you have a picture of a toilet with mom and dad assisting, but you have other pictures of other adults where it's not okay? That would be my first recommendation for that.
I'd like to add something, too, that I attended a training a few years ago about teaching sex education to children with developmental disabilities. Paul is familiar with that training. It was mostly attended by parents, mothers, and most of them had never been inside a men's bathroom, and they did not understand the etiquette of being in a public men's restroom. So we took a little field trip into the men's bathroom at the training center and talked about etiquette for men, which is very different than etiquette in a women's bathroom. I thought that was just interesting, and sometimes it's not, it's best to help the kid, but sometimes it's training the parents and things they don't know. They don't know.
And there are several, so if you ever run into families and you're working with them, there are several books that are available for purchase, but they're listed on the NCOSB website. And if you ever run it, there are certain books that have pictures that outline these teaching curriculums to teach that exact skill of bathroom etiquette and what is appropriate and inappropriate within the bathroom context. That I could share with you if you can't find it. What other questions do you guys have at this time? Because that was a pretty brief and quick overview.
Certainly know what it's like to be on a webinar. This is a lot of information, and we really appreciate Paul's expertise and knowledge. The PowerPoint was just amazing, and always good to to wrap things up, at least on a PowerPoint, with free stuff. We encourage you to go out and look at that. We do have about 5 minutes left, maybe a little bit more than that, 8 minutes, and I really want to be able to use this time for you all to ask questions, get your comments about working with youth with developmental disabilities, et cetera. I think Dr. Solowski has a question. Jane, what's your question?
At the time, if other folks had questions, but one thing I've heard from teams over time is how to decide a youth who has developmental disabilities, when could they be integrated in their current group structure and with some support, and when does a separate family approach is really needed? And realizing that has an individual case-to-case decision-making, but wondered, Paul, if you had some thoughts and some broad things to think about for that.
Sure, absolutely. Because again, I think trying to figure out what is the best treatment format can sometimes be the most challenging within our systems that we work. Minimum requirements for group treatment, I feel like, to be effective for kids with developmental disabilities, is they do have verbal abilities to have some reciprocal or back and forth communication with their peers. They want to be social, so they're not a better term, reclusive to environment. So they have a desire to want to fit in with their peers, and that they have some ability to have a back and forth communication system with them. Would probably be my only two requirements to fit into group. Other concerns that would be potential rule-outs for group, or if they have, and this is again with almost every other peer as well, is high rates of extremely disruptive behavior. So some kids with developmental disabilities have certain routines or habits, high rates of problematic sexual behavior in terms of making jokes or saying things repetitively, and understanding the ability or shaping the ability for them to control impulses and those habits would probably be the third thing that I would look at that would say yes or no for group or no group. The big three. Sorry.
Thank you, Paul.
Anyone else in the last 5 minutes? Virtual chocolate.
I'll take some chocolate. Something.
I was just going to say, this is Blair from New Jersey. I don't have any specific, questions at this point, but I just want to say thank you. I think all the information was so helpful and informative, and I think it kind of reaffirmed my understanding of the population and, just my own kind of thoughts as far as who would be contraindicated for group and so on. So I really just appreciate the information, and I'm sure I'll be reaching out to you, Paul, in the future, if that's all right, because in Jersey we're looking at potentially expanding our services to treat this population.
Absolutely. Thank you for that feedback, and I would be happy to do more. And I think the big part of this webinar is really to advocate for these kids and to advocate for your skills, because you have the ability to help in these families.
Hi, this is Sue.
Go ahead.
I want to echo, this is an awesome PowerPoint and presentation. I have a technical question. What I'm seeing in my state is that, I don't know if it's a push, but a belief that when assessment is needed, that because I work with the state needs to find a certified behavior analyst. Who does these assessments? Does it need to be a certified analysis, functional behavioral analysis in every case? And so thoughts on that would be appreciated.
Sure. I think there are two issues within that statement. One is that board certified behavior analysis, as a profession and as a licensure and as a healthcare professional across the nation is continuing to expand. And they really have a strong arena within those that work with intellectual and developmental disabilities. And in several states, they have very close relationships within school systems, as well as just the mental health system in general. And so with that recognition and with mandates for Individuals with Developmental Disabilities Education Act, if kids are having these issues in school, most state policies say that a functional assessment is a requirement to initiate services within a school setting. If you would look at who is appropriate to provide a functional assessment, the political arguments, I think, from the psychology world and from behavior analysis world, that each individual field has its own strengths and has its own weaknesses. So who is most appropriate? It depends on a number of different variables. Comfort, ability to assess, payment and reimbursement. There are several factors. Is there something in particular you think driving that push within your community or state?
I think it's a comfort level for people, caseworkers, to be able to say, oh, they're certified, so let's go there. But then what they're finding is Medicaid doesn't pay. So there's this dilemma.
And I don't know, for those of you that are still on the computer with the slides, but the thing in the intersecting systems slide where it talks about intellectual disability, juvenile justice, child protection, mental health, then intellectual developmental disability camp, or that circle, really is the school and the BCBAs that are providing that treatment. And so every state is different when it comes to recognizing those professionals. And most of the time right now it's done through schools. I would, again, advocate for our professionals working with this program to act within their own communities to push that, yes, we are acceptable and identified providers for this population. Encourage the school, if the behavior is just happening in the school, partnering with whoever the behavior analyst is or school support personnel to develop these behavior plans.
That's very helpful. Thank you.
Well, we're right at the hour. It went by so quick. I want to thank Shawler for taking time today to share with us his knowledge and experiences. Thank everyone who's attending the call today. Those of you that had questions, speak on. We really appreciate that. Thank you all very much. Have a great weekend. Our next call will be in 2 months. Will be Jackie Page, who is a psychologist out of Tennessee. He'll be talking about adolescents with illegal sexual behavior, an overview of what do we know. So thank you again very much. If you need anything from us, do not hesitate to reach out by email or phone.
I'll call her here in a little bit.
Otherwise, we will talk to you again in 2 months.
Thank you.
Bye.